Okay, so my clinical pattern was a rotator cuff repair, specifically an arthroscopic repair of the rotator cuff. This can include any of the muscles of the rotator cuff, so supraspinatus, infraspinatus, subscapularis, or teres minor. Some common patient demographics are that symptomatic rotator cuff tears are seen in about 4 to 32% of the population, and then there's 30 to 50% of individuals ages 50 or older are affected by a rotator cuff tear, and it's more common to see rotator cuff tears in men than it is in women. So a common history is their most likely mechanism of injury is overuse. However, it can also be caused due to trauma. For this, because it's a post-op, there is no aggravating or easing factors or a 24-hour pain pattern. So next, looking at precautions and contraindications for your initial exam and your first interventions. There's no active assisted range of motion or active range of motion until 12 weeks post-op. There's no weight-bearing resistance or lifting objects of that arm post-op. No shoulder motion behind their back, so reaching behind. And then no excessive stretching or sudden movements. So this is just generic, but also pay attention to whatever protocol that the surgeon gives with the patient once they're post-op. Next, looking at their physical exam, starting with observation, there's most likely some sort of scarring and wounds for healing after the operation, as well as potentially some inflammation, and then most likely they're in an immobilizer. For active range of motion, you should not perform shoulder range of motion, but you should expect within normal limits of elbow, wrist, and neck active range of motion. For passive range of motion, it's most likely limited in the shoulder, looking at flexion, internal rotation, external rotation, and abduction for the first 12 weeks. And then for the next parts of the physical exam, they should not be performed, and that includes resisted testing, neurodynamic testing, accessory mobility testing, or special tests. And then lastly, looking at palpation, there's most likely some sort of inflammation around the suture areas, as well as potentially some tenderness and trigger points in upper trap and levator scap, just because of guarding, even if they're in the immobilizer. For diagnostic imaging, they may have had an MRI prior to the surgery, but that's about it. And then for signs and symptoms for referral back to their physician, that would include fever, unresolving numbness or tingling down their arm, excessive drainage, or uncontrolled pain. Cool. Thank you.